Good evening, everyone. Thank you for joining us tonight for the first session in Hazelhurst CPD series in 2025, discussion and medical update on respiratory and inhalation diseases or diseases by inhalation. My name is Lydia Koenig. I'm CPD Program Officer here at Central and Eastern Sydney PHN. And working with us tonight, Bertha Harvey, who is CPD and Events Manager. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. And I'd like to extend that respect to Aboriginal and Torres Strait Islander colleagues joining us tonight. Please be advised this webinar is being recorded and we'll make it available on our YouTube channel in the upcoming days. This session is accredited for 1.5 educational CPD activity hours, and additional activities collectively are worth of 6 CPD activity hours. As always, evaluation survey will pop up on your screens at the end, and we'll also place it in the chat box about 5 minutes before the end of this session. Please fill out evaluation surveys to allow us to issue your certificates of attendance and to upload RSCGP CPD hours. All the upcoming events are on our website. Please visit to register. And also just quick reminder that we're in a process of finalizing topic for the heart series. And as we've done in the past few years, Southern Heart Clinic would run it for Sutherland Shire and St. George region, and Eastern Heart Clinic for the eastern suburbs. Registrations will be available on our website. And now I would like to pass it on to our GP facilitator, member of Advisory Committee, Dr. Matthew Gabbett. Thank you, Matt.
Thanks, Lydia. Welcome, everybody, to our first session, first meeting for the year. So I'll just introduce our 2 speakers tonight on inhalational lung disease. So firstly, we have Dr. Janet Rimmer, and she's a respiratory physician trained in Australia, and did a thesis on histamine releasability in asthma in Sydney, and she's also did some research and work overseas in London. She's primarily a clinician, but a member of many professional organisations, and does some work at St Vincent's Clinic and St Vincent's Private, and some research with the Woolcock Institute, which you've probably heard of. But importantly for tonight's talk, she's also worked at the Dust Diseases Care, which I think is the new name for Dust Diseases Board, but we'll find out, for 30 years. So she's done that for a long time. So our other speaker is Dr. Sugeesh Pathirana, and he is an occupational and environmental medicine physician with 15 years of experience. And he's done a lot of things in his career in that space. And yeah, also does work as an independent medical examiner for workers' compensation, and enjoys complicated work injuries, it says here, which is a good asset for us to know about. But particularly interested in occupational lung diseases, which of course is why he's going to be speaking to us tonight. And he's been with Dust Diseases Care for about 5 years. So we're very fortunate to have both these speakers tonight, and I'll pass over to them. They've got a presentation where they'll be sort of sharing different parts of it. And at this stage, we'll probably have questions at the end of the whole presentation. So if you sort of send them through and we can address those at the end, that'd be great. So thanks. I'll pass over to Janet and Sugeesh. Thank you.
Right, thank you, Matthew, for your kind introduction, and thank you, Lydia, for all the work behind the scenes. So, as Matthew has said, Sugeesh and I are going to play tag, talking to you about inhalation-induced dust diseases, which has been very topical given the increased amount of silicosis due to artificial stone work. Next slide. So the outline of the talk is I'm going to give a little bit of an overview of DDC, or Dust Diseases Care, as an organisation. We'll talk about clinical and diagnostic aspects of silica and asbestos related diseases. Sugeesh is going to cover occupational aspects, which is very interesting. He'll also talk about screening, who, what, when, and where, and then we'll come back a little bit to other aspects of the DDC. We were going to include a case history, but I think due to time, that might have dropped out, but we're very happy to talk to you about any cases that you might present, or we could give you an overview of what actually happens through DDC. And then I was asked to give a brief overview of vaping, which I'm happy to do. Next slide, thanks. So next slide, thank you. So what does dust disease care do? So who we cover are people working in New South Wales who are exposed to dust while they're working. So we don't cover people from other states who've worked with dust, or people from overseas who've worked with dust. So it is a New South Wales organisation only. They need a diagnosis of a disease related to dust exposure, and they need to be impaired. And those people are eligible for compensation through DDC. As I said, we don't cover overseas workers or other states. We don't cover federal government. So people who work in the armed forces, they have their own mechanism of compensation. We don't cover coal miners. They also have an alternative mechanism of compensation. And we don't cover people who are self-employed. DDC is covered by New South Wales state legislation. So it's a statutory body, and the diseases that we cover are listed in the statute, which was last updated in 2023. Presently, we cover about 19 diseases, and I did have a slide with a list of all of those. Asbestos-related diseases and silica-related diseases are the commoner ones, but there are a number of other ones, including berylliosis, bagasosis, hypersensitivity pneumonitis, and so on. So you can access that list if you wish to, and see whether somebody who presents with an occupational related disease to your practice might be eligible, or they can come in and be assessed, and we would tell them that. And it's important to say that currently we do about 5,000 screenings a year. So we screen both in the CBD, and we also screen with a mobile van. A new one was launched only last week, and that goes to remote places in New South Wales so that workers can get access there. And Sugeesh right at the moment is in Newcastle, because that's where the van is at the moment. Currently, we are compensating close about 1,800 workers, and we also compensate their dependents. So that can be spouses, or it can be children up to the age of 18. We also provide increased care in the last phases of life, so a palliative care path, if you like. But there's quite a lot of benefits that can be obtained through DDC, which I think often people are not aware of, but it is important to be aware of those. Okay, next slide, thanks. So I'm just going to talk about a little bit about the pathogenesis. So just a couple of slides about that. So these are pictures of asbestos fibers and silica particles, and you can see that they're quite different. The asbestos particles are long and thin, and as a result of that, they get inhaled. Macrophages cannot deal with asbestos particles, so they actually transit through the lung tissue towards the periphery and end up in the pleura, where they will generate pleural plaques, etc. Silica particles are small, and you know, not all silica can be inhaled. So, for example, sand at the beach is silica, but we don't have a problem there. We don't tell people not to go to the beach. The next slide is just showing you that when you inhale a particle, there are quite a few parameters that determine whether it's going to be deleterious, including the composition of the particle itself. So some things that we inhale are, relatively innocuous, but silica and asbestos are not. And then there are other characters of the particle, such as particle charge, particle size I've mentioned. There are also personal factors that are important, so genetics and epigenetics. So from working at the Dust Diseases Board for many years, what is very remarkable is that people who worked in James Hard end up with asbestosis or with mesothelioma, and another worker would not. So this is, going back to the genetics and the epigenetics, associated with those diseases. Okay, I think this is probably the right one. Thanks, Lydia. Look, I've gone through that one already. So so this is the list of scheduled diseases. And the ones that I've highlighted in yellow are the ones that we're going to talk about today, but you can see that there are a few others. Okay, so I'm going to talk about silica-related diseases because this has been in the media a lot, and there's a lot of interest and a lot of screening related to this at the moment. So the first case was detected in Australia in 2015, and we now have about 1,000 cases. And it is mainly due to the introduction of artificial stone. There has been, a great fashion trend in using artificial stone in kitchens and bathrooms. I mean, it's a very good product, just as asbestos-related products were also very good. But you can see that we're paying the price for using this. If people develop silicosis due to artificial stone, instead of natural stone, so maybe working with bricks or cement or other stone products, there is a shorter duration of exposure before they develop a disease. The disease is more rapidly progressive and there is a higher mortality. Next slide, thanks. So this slide shows you two chest x-rays of silica-related disease. So on the right-hand side is simple silicosis, which are multiple small nodules, particularly in the upper zones. And on the other side is progressive massive fibrosis, which is when silicosis, it can be simple silicosis, is complicated by the development of fibrosis in the upper zones. And this would be associated with a restrictive lung disease pattern. Next slide, thanks. So in silica-related diseases, you can get lung nodules, which I've just shown you. So they can be acute, which is very uncommon, accelerated. So this would be artificial stone with exposure for 1 to 10 years. So you'd be looking at people. I mean, a lot of people start in the industry when they leave school. So you might be looking at people in their 20s or 30s often. And also chronic, where they have exposure over 10 years. Progressive massive fibrosis, I've mentioned, and I've shown you a slide, but you can also get related to a silica exposure, COPD, chronic bronchitis, and also an increased risk of lung cancer. And we'll come back to that later. Other complications, which you just need to keep at the back of your mind, are tuberculosis. There's an increased risk of tuberculosis with silicosis, chronic kidney disease, autoimmune diseases, including scleroderma and lupus, and also ocular irritation. Next slide, thanks. How do you make the diagnosis? So you need a consistent history. So somebody who has worked in the industry, and Sugeesh is going to walk you through some of that. And it is, occupational medicine is a specific specialty. And as a GP, you wouldn't be expected to know all the occupations that are relevant. But at DDC, that is something that we, spend a lot of time working out. So if somebody has had a high exposure, so people who've worked with artificial stone and they haven't had adequate PPE, up to 30% of individuals can be affected. They may present with an abnormal chest X-ray, but it's also important to know that the chest X-ray may be normal, but if you have a high index of suspicion, particularly if they've been working in that industry for a long period of time, and let's say we define that loosely as 5 years, 30% may have an abnormal CT. And we have a very low threshold for ordering CTs in the presence of an abnormal chest X-ray, but a history of high exposure. Abnormal CT and lung function can vary from being completely normal to abnormal. Next slide, thanks. This gives you an example of one of our cases where the chest X-ray was within normal limits, so no evidence of nodules, but the CT scan shows nodules and does also show an area of emphysema in the right midzone. This person had normal spirometry, so FEV1 86% predicted, FVC 109% predicted normal ratio, but the DLC was a bit reduced. This is often an issue in the DDC. Is the DLCO reduced because of the silicosis, or is the DLCO reduced because of smoking? And that always forms part of the discussion when you're trying to attribute disability to different diseases. In general, I would say with my long-term experience with the DDC, the outcomes are generally as favourable as they can be to the worker. Next slide, thanks. Treatment of silicosis, a lot of the time it's just monitoring. Whole lung lavage has been used for acute silicosis. Trial of steroids used, but not necessarily beneficial. Antifibrotics are now coming onto the stage, and in the UK they have been approved for use, but the trials demonstrating their efficacy are still underway. But I think that will probably be the direction to go, certainly in the future. Lung transplantation has been used in Australia for PMF and also acute silicosis. And obviously there's also targeting of the complications. Another area which would come, just go back to that slide, thanks, which would come into treatment or management is, should the person continue working, yes or no? And that is an interesting dilemma, and Sugeesh is going to address that. So now I'm going to hand over to Sugeesh, who's going to talk about occupational related aspects of silicosis. Thank you, Sugeesh.
Thank you, Janet. So in my part of the talk, I'll be focusing mainly on the occupational aspects of silicosis. Please, next slide. Next slide, thank you. So silica is no, the slide before, yeah, thank you. So silica is a naturally occurring mineral found abundantly in sand and rock, or various construction material. So silica exists in two forms, crystalline and amorphous. And crystalline form is highly toxic to lungs, and particularly the particles less than 10 micrometers in diameter, which Janet mentioned before, which is also called respirable crystalline silica. So that's what we are mainly concerned about. And generally, respirable crystalline silica is generated by using power tools or mechanical plant to carry out activities involving a substance which contains crystalline silica. Next slide, please. Yeah, so this is to point out, differences in the crystalline silica content depending on the material that workers handle. Most of the natural stones, such as marble, limestone, or granite, has a lower crystalline silica content compared to engineered stone, which Janet mentioned, or artificial stone, which has a very high crystalline silica content, ranging from 90 to 97%. And also there are other materials such as aggregates, mortar, concrete, and tiles, bricks. They have substantial content of crystalline silica. Next slide. So this is a list of activities, this slide and the next slide, and which workers mostly commonly get exposed to silica dust. And I mean, this is a long, list, and I'm not going to go through the list, but essentially these are activities in jobs, involving mining, construction, tunneling, manufacturing, moving, quarrying sort of industries. So, I mean, if you come across someone, who undertakes work in these industries, you should be vigilant, whether these people might be exposed to high levels of crystalline silica. Next slide. Next slide. Thank you. Yeah, so in the next few slides, I'm going to, present some figures and numbers to highlight the, extent of the issue of silicosis in Australia. So for many decades, silicosis has been a very rare disease in Australia. Very relatively few numbers until 2018 and 19, typically 20 to 30 compensation claims per year in Australia. Historically, silicosis were primarily seen in industries such as mining, tunneling, and quarrying. But in recent years, there was a sharp increase in the number of cases of silicosis, primarily driven by the stone benchtop industry and handling of engineered stone. Next slide. Next one. Yep, thank you. So this is a previous slide. Thank you. Yeah, so this is from a study conducted in by the Monash Centre of Occupational Health and Environment in Victoria, and they've looked at two sources of data, workers' compensation cases in Victoria, and also cases diagnosed in a bioclinical registry. And you can see from the graph that there's a sharp rise since 2018, which is primarily due to the cases diagnosed in the engineered benchtop industry. Thank you. Next slide. And these are numbers from New South Wales. And you can see in the graph on the left, these are compensation claims of various dust diseases from 1992 to 2011. And the gray line, the second gray line from the bottom illustrates the cases of silicosis. I don't know, I'm sure whether it's very clear, but it's showing that, the number of cases averaging less than 20 per year. But you can see the graph on the right, a sharp increase in cases since 2018, again, attributed to the stone benchtop industry. Thank you. Next slide. So also a study conducted by Curtin University in Western Australia in 2022 estimated that nearly 600,000 Australian workers are currently exposed to respirable crystalline silica through their work, and projecting over 10,000 lung cancers and 100,000 silicosis cases in their lifetime from their current silicosis exposures. Next slide. Yeah, so patients, individuals exposed to respiratory hazards in their workplaces might present to your clinic in different ways. Some patients might have symptoms such as progressive shortness of breath, persistent cough, and it's really important to remember to take a occupational history in these patients to try and sort of, see a link between their presentation and their exposures to respiratory hazards in their current or previous workplace. Or some people might come not because of their symptoms, but are concerned about their current or previous workplace exposures. And again, taking a detailed occupational history is really important to determine the level of their risk of exposure to respiratory hazards, in this case, crystalline silica. Now, some of the times the employers might request for their employees to undertake health monitoring assessments because of the work that they do with crystalline silica, which is a statutory requirement under work health and safety regulations. So they might come to you, to complete that assessment. again, some people might actually come to see you with the established disease, which is with a diagnosis of dust disease. So in that case, it's more about, playing active role in managing that condition and also monitoring of the condition in a multidisciplinary team environment. Next slide. Just skip that slide, the next one. Thank you. So in Australia, it is a mandatory requirement to undertake health monitoring for workers who are exposed to hazardous substance at work, including respirable crystalline silica. Now, under the legislation, persons conducting business and undertaking, which is, we probably can say the employer must provide health monitoring for workers if they carry out any work having ongoing exposure to crystalline silica, and there is a significant risk to the worker's health because of that exposure. Now, also the employer must engage a medical practitioner with experience in health monitoring to carry out that health monitoring assessments. Now, the medical practitioner doesn't have to be an occupational physician or respiratory physician, but it can be a medical practitioner with some experience in health monitoring. Now, employer will pay the cost for cost involved in health monitoring under the legislation, so they must pay the cost. Next slide. Now, also the legislation requires the employer to arrange health monitoring before a worker starts, during and at the end of work involving crystalline silica. And this table outlines, the components of health monitoring at each stage, but they're pretty similar requirements at each stage, and it involves taking a medical and occupational history, looking at their records of personal exposures if they're available, and administering a respiratory questionnaire, undertaking physical examination focusing on mainly respiratory system, but also looking at joints and skins. As we know, silica exposure is associated with increased incidence of autoimmune diseases, and also undertaking spirometry and a chest x-ray as per ILO standards, and additionally undertaking high resolution CT scan of the chest depending on the exposure levels or presence of any abnormalities in the investigations, which I mentioned before. Next slide. Now, I think it would be very useful for you to know a little bit about, taking some practical approaches to taking a detailed occupational history, because taking an occupational history is very time consuming and complex, and some people might have work history spanning over many years. I think it's very important to set aside some sufficient time. I know in GP practice, the time is quite limited, but I think it's a key part of the risk assessment, and it actually tells you the level of exposure, the risk of level of exposure for someone, so you can actually order appropriate tests based on their exposure levels. Now, there are many pre-prepared templates and questionnaires available. SafeWork Australia has a good sort of a guidance on taking occupational history, and also a questionnaire available in that website. Next slide. Now, there are different ways you can do it. I generally prefer start with their current occupational role. And one of the problems is I find that the job title can be quite deceiving, because it not necessarily explain what actually they do. So don't assume, don't be embarrassed, just ask actually what they do in their job. So you will be surprised, it'll be different to what they actually, the job title says. Now, ask about their dust exposures at work, and if yes, and ask about, how do they get exposed, and particularly very important to ask these dry mechanical processes using power tools, because that's where most of the respirable crystalline silica exposure happens. Now, and also ask about what materials they use, whether it's concrete, whether it's sandstone, because we know from previous slides, based on the material, their content varies. How long have they been doing that role for? And do they work full-time, part-time, and do they do overtime? You know, some people work for 12, 14 hours, they have more exposures. And do they have control measures at work to minimize or prevent dust exposure? So I'll talk a little bit about later on about the control measures. And do they use respirators, and what type of respirators do they use? And have they undergone fit testing? And also ask about whether they have received any information, training, or education about the nature of the hazards that work with, or the safe work practices. And don't forget about, because we are focusing here on a respirable crystalline silica exposure, but ask about other respiratory hazards they exposed to. Next slide. And then obviously you ask about the previous jobs with dust exposure, and take a similar exposure history at each, about each role, because you have to assess the exposure risk at each job, because it's a cumulative exposure for so many years. There's a long latency period from the time of the exposure to the development of the disease. Sometimes you will find that their previous jobs much more relevant than their current exposures. And do they do secondary employment, cashing jobs on the weekends? So that might be much, higher exposures than their actual job in their during the weekdays. And do they have any hobbies which exposes them to silica, or do they have environmental exposure? I mean, you assume that they probably will be very low level exposures. And of course, the medical history, I don't have to go into details. You're very familiar with taking a medical history. Don't forget about the smoking. It's really important to ask that piece of information. Next slide. So a little bit about control measures, the hierarchy of control measures. I think it's really important to understand the concept here, because it's really depending on what level of control measures users determines their level of exposure. Now, you see here in the hierarchy of controls, there's an upside down sort of triangle. So this hierarchy of control measures ranks the control measures in order of, from most reliable to least reliable, and also the highest protection to lowest protection. So you can see at the top, it's the elimination of the hazard. Good example, last year, government banned using engineered stone. So you're actually pretty much eliminating the hazard. So you're removing the hazard. So that's one of the most effective methods. And then it goes down to substitution with a less toxic material, and then isolation of the worker from the hazard. You can make the process automated. So, and the engineering control measures. So you can see from the pictures here, there are some dust extraction systems attached to the tools. So it extracts the dust at the source of dust exposure, and also attached water, supply to the tool. So wet suppression. So they're really effective methods. So they're considered the higher order controls. But when it comes to administrative controls and personal protective equipment, such as masks, are the least reliable and least protection. So, but most, often we find that workplaces only rely on the masks only without other control measures. So if you take the history, and if they say to you, we are only using masks, no other control measures, definitely they're at high risk of exposure. Next slide. Now, no talk about silicosis is complete without talking about artificial stone industry, or the engineered stone benchtop industry, because the new epidemic of silica-related disease. I know Janet actually, mentioned about this. I'm not going to go into much details, but I just want to highlight that this industry had very unique risk profile compared to a lot of the other silica-related industries in the past, because they dealt with a very high material with a high content of crystalline silica. They used high intensity power tools to cut this material. And because of the nature of the business, small and medium-sized business, they had little or no dust control measures. And nearly half of the workers were migrant workers. As you know, they have limited English skills. They have lack of understanding of safe work practices. No wonder, it's a perfect recipe for a disaster. Next, paragraph. So next slide, sorry. Now, I included this slide just to make you aware that if you're assessing someone who worked in this industry, engineer stone benchtop industry, is a really good guidance here, guideline, national guidance, which is a publication done by the Department of Health in 2021, I remember. And it actually really gives you good sort of, resources. And if you're doing an assessment for these workers, you really need to be familiar with these sort of the guidance. And because of their high risk profile of that industry and the exposure levels, and it recommended all stone masons to undergo annual health monitoring, undergo a complete lung function test, which is not only spirometry, but lung volumes and diffusion capacity, to do a blood test to screen for autoimmune diseases, and arrange high resolution CT scans for high risk or very high risk workers. Next slide. So just want to highlight a few things about the role of investigations. Now, because of the resurgence of cases in silicosis since 2018, there had been a number of studies performed in Australia. One is to have to improve our understanding of the role of investigations of screening in this cohort, like engineered stone benchtop workers. Now, one of the studies I've included here, conducted by Monash University, involving engineers on benchtop workers, and the results of this study demonstrated that there is very poor sensitivity of spirometric parameters in predicting silicosis in engineered stone benchtop worker cohort. What that meant was, spirometry appears to be a pretty blunt tool in terms of screening purposes. However, it has its own place in a longitudinal monitoring of spirometric values over the years of a worker, and there are some studies available to suggest that diffusion capacity is a much better predictor compared to spirometric value in detecting early functional abnormalities in silicosis patients. Next paragraph. Now, similar to lung function test, the studies performed over the last few years improved our understanding of what the most appropriate method, imaging method of investigation or screening and detecting early changes in silicosis. Now, again, a similar study done in Monash University, published last year, have shown that there's poor sensitivity. Chest X-rays has poor sensitivity in detecting early changes in silicosis. And with high false negative rates. What that meant was significant proportion of workers cases were missed if they relied upon chest X-rays only. Now, in contrast, high-resolution CT scan showed far more greater sensitivity in picking up early changes due to silicosis, but it comes at a cost because they're less available, they're costly, and they use a high radiation dose. Now, Royal Australian and New Zealand College of Radiologists, in their position statement, strongly recommended that if you're ordering a chest X-ray for screening purposes for occupational dust diseases to be performed and reported as per ILO standards, and also utilizing high-resolution CT scan for screening engineered benchtop workers. Now, in Western Australia, they have already adopted this, and they actually replaced chest X-rays with high-resolution CT scan in screening their workers. Next slide. The last slide in this section. It is a very good reminder. These, all the things that I mentioned before, still the occupational lung diseases exist in Australia. And as Janet mentioned, silica dust exposure not only causes silicosis, but also a whole range of other health issues. Now, it is strongly recommended, and it's a commonplace nowadays, that diagnosis of occupational lung diseases are made in a multidisciplinary environment, involvement with doctors from different specialties, and which improves the diagnostic accuracy, and which in turn improved work outcomes. And last thing you want is to have an incorrect diagnosis, which has substantial implications to the individuals. Thank you. Over to you, Dr. Janet.
Thank you, Sugeesh. As I said, I've worked at the DDC for a long time, and the original cases of silicosis, a lot of them were, again, migrant workers, and it's useful to remember that Sydney is built on sandstone, and a lot of jackhammer operators develop silicosis as a result of that work. So if you get an elderly person coming in and they haven't worked with artificial stone, useful to check their history as well. So we're going to switch over to asbestosis. And we have a lot of cases of asbestos-related disease which are compensated through the DDC. Now, I'm going out of state to show you a picture from the Wittenoon Gorge disaster in Western Australia, which was operating between 1930 and 1966. And this was associated with over 2,000 deaths due to asbestos-related diseases. And in one slide, you can see the actual mine itself. And on the other side, you see children playing in asbestos tailings. This didn't really occur in New South Wales, but certainly I have come across workers who as children were handling asbestos materials. People who worked in James Hardie would describe white dust throughout the factory, and even the people who worked in administration there were at risk of developing disease. So exposure was quite extreme. And also, workers will tell you, and we know, that the dangers of asbestos were known well before anything was done about it. And that is a shameful part of our history. Next slide, thanks. So asbestos-related conditions, like the silica story, there are several. Pleural plaques are commonest. ARPD, which is asbestos-related pleural disease, which is more extensive pleural plaques, and I'll show you pictures of that shortly. Pleural effusion, which is benign. Mesothelioma, which is universally fatal. Asbestosis, which is a form of interstitial lung disease. Increased risk of lung cancer and COPD. Next slide, thank you. So these are two chest x-rays. On the right-hand side, there's a combination of plaques. So you can see the calcified, thickened pleura laterally on both sides, and also going across the chest wall, those sort of serpiginous calcifications. So plaques will become more calcified as other organs do over a long period of time. And you can also see in this slide that there's calcification over both hemidiaphragms. There's obliteration of the costophrenic angles, and that's when you start to think about ARPD, and I'll talk a little bit more about that later. The other slide shows an example of asbestosis, which is indistinguishable from usual interstitial pneumonitis. Next one, thanks. So pleural plaques, they're often picked up incidentally. So when somebody goes to have a chest x-ray prior to a hernia operation, the plaques may be picked up, and that causes a bit of an alarm at the time. Ones, for example, in this chest x-ray here, they've got this sort of serpiginous appearance. There's really nothing else that this can be, so it's quite easy. But if they're just small rounded areas, It may be hard to know whether they're actually on the surface of the lung or inside the lung, and you're dealing with some other pathology. And in that case, you may need to think of doing a CT scan. They are asymptomatic unless it's ARPD. In the past, workers have claimed that they cause chest pain, but surveys over the years suggest that no, really, they are asymptomatic. ARPD is defined as being over 3 millimeters thick. It's quite long and it's quite wide, and it involves the costophrenic angles, and it is associated with lung restriction, whereas plaques are not. Plaques indicate that the person has been exposed to asbestos. That then indicates that they are at risk of other asbestos-related diseases, depending on their exposure and the time from exposure. So although a pleural plaque is benign and people should be reassured, at the back of your mind, you as a medical practitioner need to know that there are increased risks of other diseases. You don't necessarily have to tell the worker that, but you know, it would be an argument for continued monitoring. Next slide, thanks. How do you make a diagnosis? I've sort of covered that. A fairly typical appearance: chest x-ray, CT scan if you're not sure. Occupational history will sort of confirm what you're thinking. And if you're worried about the appearance, if you think maybe this is a mesothelioma, it's not just ARPD, consider PET scan and or biopsy. Next one, thanks. Treatment for the plaques, nothing, but as I mentioned, monitoring may be appropriate. Next one, thank you. So there are other pleural diseases. So I've mentioned plaques, ARPD I've mentioned. This CT scan here shows what we call rounded atelectasis, where there's a sort of an invagination of the pleura into the lung tissue, and it gives you this rounded, walled appearance with adjacent fibrosis. So this CT shows you quite nicely what plaques look like on a CT. So on the right side of the chest, you can see a calcified plaque anteriorly. So normally the pleura just covers the ribs. There's really no space between the bone of the ribs and the lung tissue. But in that plaque anteriorly, you can see that there is thickening and there's calcification. On the other side, you can see that that's even more exaggerated and it has rounded atelectasis. What would that mean? Possibly it would mean that there might be some impact on lung function. This is not really in the right place for ARPD, but this CT scan's actually in the middle of the chest, so you don't actually know what's down at the bottom. So, and then you can also get a benign pleural effusion, and you know, that would probably need aspirating to make sure that it wasn't malignant. Next slide, thank you. So mesothelioma, in Australia, we have about 700 to 800 cases a year. It really is mainly a male disease because it's occupationally related, but that's not to say females don't get it. So one of the histories at Wittenoon and elsewhere was that when workers came home with their clothes full of asbestos, their spouses would wash those clothes, and some of them were affected. The rate for mesothelioma is 4.2 per 100,000 males. There is a very long latency period. We did a study years ago in the DDC, and it was an average of 34 years from first exposure, and that hasn't really changed. Presentation is usually chest pain, shortness of breath. The mesothelioma may occur, it's usually pleural, but it can occur in the peritoneum. And if that relates to working with asbestos, that is compensable as well. Investigations: chest x-ray, CT scan, PET scan, and pleural biopsy is highly recommended to make a definitive diagnosis, because everyone with mesothelioma with a definitive diagnosis will get 100% compensation from the DDC. And also, biopsy of tumours now is becoming increasingly important with targeted immunotherapy. And treatment includes radiotherapy. So now that people with mesothelioma are living a little bit longer, I've certainly seen it metastasize to bone. So radiotherapy would be appropriate for that. Chemotherapy, there have been quite a lot of advances in chemotherapy, and often tissue is required for that, for targeted chemotherapy. Years ago, there was a trend towards doing a pleurectomy. Now that involved removing all of the pleura around both of the lungs and around around the heart. It was major surgery, but it was thought that it could be curative. That has been closely looked at in 2 studies, and it is now not recommended. So surgery is not recommended. It's not recommended to remove plaques, to remove ARPD, or to remove mesothelioma. So that is quite clear. Prognosis of mesothelioma currently approximately 18 months. Next slide, thank you. So asbestosis. So this is fibrosis in the lungs. This occurs after about 20 years exposure. It's usually heavy exposure. It's a UIP, or a usual interstitial pneumonitis pattern of pulmonary fibrosis. It has a better prognosis than idiopathic or UIP prognosis, but that is still not great. Treatment. So for asbestosis, it's generally been symptomatic. So pulmonary rehab, always recommended. Oxygen if required. Steroids generally not recommended, but I think what's going to come in this place are antifibrotics. Nintedanib, which is used for other interstitial lung diseases, has been approved in the UK for use in asbestosis. Probably when the trials come through, it will be approved for asbestosis at present. Now, to give you an example, if you were not able to access nintedanib through the PBS, and it was a diagnosis of asbestosis, that is the sort of thing that the DDC could pay for. So it just gives you an idea. And they could also pay for oxygen therapy. So a lot of their decisions with providing care to patients is made on a case-by-case basis. And they're not constrained by other guidelines that might apply to authority prescriptions or oxygen prescribing, etc. So that there is some more flexibility in the system. Next slide, thanks. This is a CT scan of asbestosis or UIP. Investigations, again, occupational history should be consistent. You would do a chest X-ray, which would suggest that there was an interstitial lung disease, particularly in the lower zones. You'd follow that up with a high-resolution CT scan. Lung function would show a restricted pattern and reduced gas transfer. And Sugeesh has already mentioned MDTs, multidisciplinary team meetings, and this is now pretty commonplace for interstitial lung disease. So one would expect that the respiratory physician and or the GP looking after the care of these patients would have presented these cases to an interstitial MDT. So this also just brings up another point about DDC. We do facilitate and make a diagnosis, but we are not working as respiratory physicians who treat patients. So if we make a diagnosis, we refer back to the GP and we say, please, could you arrange for a respiratory physician to see this patient to manage their disease into the future? We don't do that. So we assess them at differing time points, and we facilitate the diagnosis, and we work out how they should be compensated, and we manage all of that, but we don't treat. So decisions regarding treatment and going to an MDT should be facilitated by GPs and respiratory physicians. Next slide, thanks. Asbestos-related disease and lung cancer. There is an increased risk of lung cancer if you have asbestosis, and it's synergistic with smoking. So really important to try and get smoking cessation. There's also an increased risk of cancer of the larynx and ovaries. And in the DDC over the last 10 years, we have compensated 905 cases of asbestos-related lung disease with coexistent lung cancer, 4 cases with asbestos, silicosis, and lung cancer, and less than 100 of silicosis with lung cancer. But when you looked at Sugeesh's slides, this is going to change and is likely to overtake the asbestos load of compensation. Next slide, thank you. So there are 2 extra bodies that I just want to talk about briefly before I hand you back to Sugeesh. One is the National Asbestos Exposure Register. Now, this has been created by the Australian government, and just to sort of put it into common language, what it means is that if a worker has an exposure, they can document this exposure in this register. It is private, it is not bandied around anywhere. And let's say, 10 years later, they have another exposure and another. It's very hard for them to remember back for all these exposures. But if they put it into this register, it's documented and it's kept in case they require it in the future. And it would be of great benefit to the DDC to have this sort of information. There is another body that you need to know about, because workers will ask you about this. So it's the Dust Diseases Tribunal. So it is a specific New South Wales civil law court which hears cases related to dust disease sufferers and their dependents. So if somebody has died, their spouse or dependents can go to the tribunal. There's no time limit for this claim, and the decision is delivered by a judge. So let's say somebody has asbestosis, and the DDC deems them to be 50% disabled. They will receive a regular pension, but that negates their old age pension if they're already receiving that. Plus, they will receive any medical benefits related to the disease. And I've talked about pulmonary rehab, oxygen therapy, drugs, etc. They also can receive help with mowing their lawn and other household necessities. However, they can go to their solicitor, or they can go to solicitors who specialise in this area, who will present their case at the DDT, and they can get a lump sum payout. So some workers will decide to do that, and others don't want to do that. But both of these processes go along side by side, and the DDC will provide all the information that we have about the investigations that we've done to the DDT process, so that the workers can access both of these forms of compensation if they wish to. Next slide, and I think I'm handing over to Sugeesh. Thank you.
Thanks, Janet. That's very informative. I think in the interest of time, I think I'll quickly, rush through the slides. So I'll be focusing again on occupational aspects. The next slide. I think Janet already mentioned about the incidence rate. So it is, and also it is estimated that 4,000 Australians die each year from asbestos-related disease. So these actually figures show, still it's a, significant, burden to the healthcare system, and also asbestos containing materials have essentially not been used in new applications in Australia since the comprehensive ban in 2003. However, asbestos was used in over 3,000 products in building and structures built before 1990. What that means is that creates still a significant potential for further exposures, both occupational and non-occupational exposures. Next slide. So occupational exposures to asbestos in Australia occurred in 3 waves. The first wave was the workers who mined, milled or transported raw asbestos or worked in the manufacture of asbestos products. And the second wave for workers who actually used these asbestos products, like boiler makers, fitter machinists, electricians and plumbers. And the third and the current wave is the workers who actually do maintenance and repair activities or remediation work in this, the built structures which contains asbestos nowadays, which includes plumbers, electricians, and also workers who remove asbestos, either licensed or non-licensed. They have a risk of exposure. Again, demolition workers, waste and landfill operators also get exposed to asbestos exposed in the current setting. And this risk is posed by that legacy asbestos. Thank you. Next slide. Okay, so it's also really important to be aware that there's still a non-occupational exposure to asbestos occurs due to the legacy asbestos in structures and buildings which contains asbestos-containing material. Most importantly, the people who actually do renovations at home by themselves are at risk of asbestos exposure because they might not be aware of the risks associated, or they might be not know where the asbestos contains. And also, because of the extreme weather events, with the climate change, there are more and more natural events, storms, floods, and fires, which damages the structures containing asbestos, and which is a common source of exposure to asbestos. And some people may remove asbestos containing material with unsafe practices, and also dwellings in public buildings, schools, hospitals, hotels still contains asbestos. We hear incidental exposures to asbestos in these settings. Next slide. And sorry, next slides, please. Thank you. It's very so it's again in Australia, health monitoring for workers who have ongoing exposure to asbestos or undertake work in asbestos work required to undergo health monitoring. So the employers should arrange health monitoring for these workers. It's very similar to what they do with health monitoring space. It's very similar to the silica exposure. So I'm not going to go over to much detail about that, but it's again, collecting medical and occupational history, physical examination, respiratory function test, and chest x-rays still required in health monitoring. Next slide. So it's really important to remember that when leaving someone from a high-risk industry and retiring from the workforce, it is really important to inform and educate workers that they have ongoing risk of developing exposure-related disease. It's really important to emphasize the need for ongoing health surveillance, because some people say, I'm out of the industry, I'm retired, I don't need to do this. So it's not the case due to the long latency of these dust diseases. Now, health monitoring not only actually about doing just tests, but also it is an opportunity for you to discuss, strategies to improve their lung health, quitting smoking, vaping, and also to emphasize that the increased risk of lung cancer from combined exposure to smoking and asbestos or silica exposures. And also to emphasize, if they're currently employed, to talk about the effective control measures, because sometimes the employers may not be good at, implementing these control measures. Next slide, please. Thank you. So I want to, before I finish, last two slides, I just quickly talk about return to work for someone who is diagnosed with a dust disease. Here I'm more focusing on the workers with silicosis, because most of the people diagnosed with asbestos related disease are more in retirement age. So it is really complex and challenging return to workspace, because there is no single answer to this sort of return to work for someone who diagnosed with dust disease. It really depends on so many factors. If someone's at the time of the diagnosis, if they have simple silicosis, or whether they have simple or complicated silicosis, that really determines their prognosis to return to work, because most likely people with advanced disease likely to have symptoms, and that really affects their fitness for work to undertake, physically able to do their job. Now, if they the age of the worker is really important, because if they're a young worker, they have more opportunities for retraining, and the size of the business, if they're a small business, there is hardly any alternative duties available in those environments, and some people may not have transferable skills, especially in this engineered benchtop industry, and that might be really a significant barrier in retraining and finding alternative employment. Now, impact on income is one of the most significant barriers which I find, because it really depends on, when the people don't want to leave the job, because the next job that they offer or find through retraining is actually don't have the same income. So they're really resistant to change their jobs because of that reason. Now, whatever the reasons, I think really important as primary care physicians to remember that there are a lot of health benefits of good work. So a diagnosis of a silicosis or any other dust disease does not necessarily mean that they need to be, stay away from work. If we can find a suitable employment in a safe working environment, that really, helps in terms of their quality of improving their quality of life. Now, what are return to work options? Now, it is really important that they, workers are removed from further exposure to ongoing exposures from silica dust. However, we still don't know. There are still a lot of unknowns, what levels they, in terms of disease progression, we don't know whether someone with a simple silicosis with no symptoms, is it okay for them to return to work with really good effective control measures? So we still don't know the answer to that. I know there are a lot of research going on in Queensland in that space, return to work. Now, apart from removing someone from exposure, there are options for them to do a different role in the same employer or in the same industry with a different employer. And also vocational retraining is available to find jobs in an alternative industry. Now, next slide. This would be my last slide. So it's really important. I think GP, primary care physicians, has a critical role to play, but they don't need to be feel overwhelmed, because I think the return to work decision should be made in a more sort of a multidisciplinary team environment. There's there will be respiratory physician involved in their care, and you can always refer to an occupational physician for some advice. And if they're currently employed, I think it's really important that to engage an employer representative, case managers who look after their claim. Now, apart from return to work, I think the primary care physicians can play a big role in providing psychological support and giving advice on smoking cessation and encouraging healthy lifestyle. Thank you. Over to you, Janet.
Thanks. So I'm just going to give you a short presentation about vaping, and I have to confess I'm not actually an expert in this, but I've tried to put together what I feel is a reasonable amount of information. So you will all have seen people in the street who are doing this. It certainly generates a lot of smoke. Next slide, thanks. So what do vapes look like? They come in all shapes and sizes, but I guess one thing to say is that often they're very quite pretty. I mean, they're an accessory. So I personally haven't been into a vape shop, and I mean there is a lot of sort of illegal trade in vapes, so they're hidden behind the hidden behind the counter. Anyway, as you can see, they come in all shapes and sizes. Next one, thank you. So what are vapes? So they're an electronic device. They're also called e-cigarettes, QV sticks, and they're designed to vaporize a liquid which you then breathe into your lung. There is a battery, which is a lithium battery, and that itself can be a problem. And that heats a heating element that then vaporizes a flavored liquid solution. And you can see that on the picture of the vape pen that I've put in there. There's a slightly brown solution. And that then produces an aerosol, which is either actively or passively inhaled. The device can be disposable. So you will have seen devices thrown on the pavement and other places around the place. It can be refillable with liquid or pods. So all of those are different options. There are quite a few ingredients in vapes. So there's propylene glycol, vegetable glycerine, glycerol, flavors, and numerous other chemicals. And some of these chemicals we already know are harmful to human health. Nearly all vapes contain nicotine. And as we know, nicotine is addictive. It's very hard to take a vape history to understand how much nicotine people are actually inhaling, because the concentrations in the vapes differ. The number of vapes in a container differs. So the nicotine in one vape, for example, can equal 50 cigarettes. And, you know, it is quite a variation between the different products, and the user does not always know exactly what it is that they're inhaling. So it's a much harder history to take than cigarette smoking. And in fact, a smoking history is now complex, because there are cigarette smokers, you know, current and ex. There are social smokers, and it's hard to get a handle around social smoking. And then there are people who are vaping, and there can be combinations of all of the above. Next slide, thank you. So vapes were introduced into the US in 2007, and if the tobacco industry has been very clever over the years, and originally it was advertised as an adjunct to quit smoking. However, the evidence was sketchy at the most, but it passed through and they were available for use. And it has really taken us 20 years to catch up and say no. In Australia, vapes are purchased as a consumer product. They're not a therapeutic good, so they're not under the TGA guidelines. In 2016, when we started to understand that there were problems with vaping, the US Congress passed what was called the Child Nicotine Poisoning Prevention Act. And I'll talk a little bit about young people and vaping in a minute. Australia has finally caught up, and in July of last year, all vapes with nicotine can only be sold in a pharmacy. However, I believe that does not stop black market sales. So some of the, you know, fast food, not fast food shops, but the corner grocery shops, things, I don't really want to name any names, but some of the chains, they will keep vapes behind the counter and they will sell them. And then they're not supposed to, and they can be prosecuted and fined, but that process is only as good as the actual process, and at the moment it's probably not good enough. In October 2024, over the age of 18, you can buy 1 packet of vapes with a concentration less than 20 milligrams per mil. Over 20 milligrams per mil, a script is needed. And you need to provide a script. So when would you provide a script? That's something that you need to consider. And the flavors have now been restricted. So it's only mint, menthol, and tobacco. Before, there were numerous flavors, which apparently was part of the attraction, particularly to younger smokers, and we're talking here of teenagers. Next slide, thanks. So I'm going to show you on the right-hand side, this is with the colored bars, that's cigarette smoking, and on the other side, this is vaping. Now, Australia had been doing really well with smoking cessation. And in 1995, we had 27% of the population smoking cigarettes. And by 2016, this had dropped to 14%. The multicolored graph shows you smoking rates by age. And if you average that out, it's about 14% overall. On the other side, it's the bars here show you the proportion of people 15 years and over who had used an e-cigarette or vaping device at least once by age. And this was done in 2022. And what is alarming is that in 15 and 17-year-olds, 18% have tried it at least. And in 18 to 24-year-olds, it's up to 38%. So we have lost in many ways the great gains that we made with cigarette smoking cessation. Next one, thank you. So what are the side effects of vaping? Why do we care? Nicotine addiction, so it is highly addictive. Nicotine poisoning, so because the concentrations vary and there can be so many units in one vape, people can use a huge amount and can end up with nicotine poisoning. They can have irritation in the throat and coughing, breathlessness, dizziness, headaches, nausea, lung damage, which I'll come back to, and there have been quite a few reports of serious burns due to explosion of the lithium battery. So if the vape is in your pocket and it explodes, that is certainly bad news. Next slide, thank you. So why do we care about younger people and vaping? So it is well documented that nicotine can harm the developing teenage brain. The brain keeps developing until about the age of 25. And the parts of the brain that can be damaged are those that control attention, learning, mood, and impulse control. So all facets of behavior, which we know already, can be difficult in adolescence. And that nicotine changes the synapses that are developed when memory is laid down. Using nicotine as a teenager can also increase the risk for future addiction to other drugs, so they're 3 times more likely to take up cigarette smoking. The nicotine in vapes can make stress and depression worse, and it can also increase anxiety. And the nicotine in vapes can cause changes to brain development, impaired attention, learning, and memory, as I've said before. Often when people start smoking either vapes or cigarettes, they do it for the hit that they get, because the nicotine passes through the lungs through the blood-brain barrier very quickly. But that tends to go away after a while. And then why they smoke is they're avoiding withdrawal. And that drives the continuation of the smoking habit. Next one, thanks. So this is just a single slide on vaping effects in the lungs. So one of the most severe effects is EVALI, which is e-vaping associated lung injury. And at about 2000, 2020, there were about 2,000 cases reported internationally. It's an acute inflammatory lung reaction and mostly requires hospitalization. And the slides that you've got there show you that, it's like a severe COVID pneumonia or viral pneumonia, and it's quite severe. But there are other conditions as well: asthma, hypersensitivity, pneumonitis, chronic bronchitis, eosinophilic pneumonitis, diffuse alveolar hemorrhage, lipoid pneumonia, bronchiolitis, and we come back to lung cancer again. If you vape and smoke, you have 4 times the risk of developing lung cancer compared with smoking alone. So there's not really anything good to say about it. Next, thanks. So I'm just going to read through the TSANZ position statement because, you know, that's really where we are standing in Australia at the moment. So they say electronic cigarettes have adverse lung effects, and I've gone through that, and harmful, but still we don't know the long-term use. I mean, it's not been around for long enough that we know what 50 years of use is like. They are regarded as unsuitable consumer products for recreational use, part substitution for smoking. So that's where they have been pushed. If you go onto vapes, it's better and safer than smoking. And TSANZ is saying, no, that's not a reason for doing it. And that refers me back to the comment that I made, that as GPs, you need to decide when you're giving prescriptions for e-cigarettes. And to go back to, if smokers require support to quit smoking, they should go back to what has been recommended for ordinary cigarettes, which is approved medication and behavioural support, which is a forte of GPs, but there are smoking cessation clinics available in New South Wales. So in summary, no specific EC product can be recommended as safe and effective for smoking cessation. And I think that's it. The last slide just goes back to how you can contact DDC if you wish to find out more about it. And we have also provided to Lydia a list of references if you want more information about any of the topics that we've covered. Thank you. So I might hand it back to Matthew if there are any questions that you wish to bring up.
Mute. Hello, can you hear me? Right.
Yeah.
Thank you, Janet, Sugeesh. There's not very many questions. I have just one quick question. You may have said this at the start, but who pays for the dust diseases care? Like, where's the funding for that come from? So,
Sugeesh, do you want to answer that?
I think it's from a dust disease levy, I think, where the money comes from, as far as I know. If is that, I think that's
well, I can expand on that a little bit. So if a worker is being referred for a screen, the employer will pay for that. If a worker says, well, look, my employer's not doing anything and I want to go and get checked, they can refer themselves, you can refer them, or a respiratory physician can refer them, and there is no cost. The funding for the whole DDC is by the State Treasury, and hopefully that's in the black. I never quite know where it is. And yes, Sugeesh is right. The money is raised by the workers' compensation levies that all businesses pay in New South Wales. So GPs will be paying workers' comp levies. I mean, you won't be compensating for a dust disease, hopefully, but you carry that insurance because there may be other accidents that occur at work that need to be covered.
All right. So we as GPs can direct people to the dust DDC if they meet those criteria, put it on the first slide.
Yeah, well, if the worker is concerned, or if you start to talk to someone and you think that they might be working in a small workshop that is doing stone, and you're not clear about how much artificial stone they've had, and they've got a cough, and you're like, oh, this is just all a bit too much. They're anxious. I'm not sure. Send them in, and we will do a history, physical examination, a chest X-ray, and lung function. If we need to, we'll do a CT scan. That would all be free of charge to them. And then if they enter into the system and they have a disease, they go back to the GP and you refer them to a respiratory physician who manages the disease. So that's sort of how it works. I mean, it is complicated and it's hard to get your head around it, but you know, we are there to try and help out with these things if need be. And you can get in to see us quickly, like, you know, you're not waiting 3 to 6 months to see a respiratory physician. We can do that quick screen quickly, and we can say yes or no, there is or there isn't a problem. So it's quite an easy one.
And also, Matthew, sorry, were you going to say something, Janet?
Oh, well, I was going to ask a question if there aren't any others. Yeah. You go, Sugeesh.
Yeah, no, I mean, you probably, I mean, I'm not sure whether Janet mentioned, but there's a mobile clinic going around New South Wales. And, you know, if a worker requests to be, I mean, you know, if someone's retired or, you know, need to get screened, and you can actually contact DDC and say, you know, I'm here, I'm in this area, you know, can I get seen by doctors in the mobile clinic? So that way they don't have to travel to the city, but yeah.
Yeah, I mean, the other screening that's going to come in that will also affect GPs are the lung cancer screenings, which are coming in from the middle of the year. So they will be provided free of charge. So a low dose CT every 2 years will be provided free of charge to people aged 50 to 70 who have a 30-pack year history of cigarette smoking and are current smokers or who have not given up in the last 10 years. So there's still an increased risk of lung cancer. So all those, so as GPs, you should encourage any of your patients who fit those criteria to go and get the screening. And then, of course, you know, you've got to deal with the fallout of the screening and, you know, finding coexistent abnormalities, which is like another industry in itself. So you'll know all about that.
So there's obviously some evidence that that's a worthwhile endeavour.
Yes, it has been shown. It's taken a long time to get it in train because it has to have been shown to improve prognosis and to be cost effective. There would be no funding for a process unless it was. I mean, it's you know, it's like cervical screening, mammograms, etc. These things are not done unless they are cost effective.
That's a significant change.
Yes, it is.
For many years,
it's taken a long time to get it into, you know, to become active, and it's being screened, I think, June of this year. So that will be a big change for GPs to manage that. So I was going to ask Sugeesh, you know, we've all been really keen on using artificial stone, you know, Caesar stone and other brands in our kitchens and bathrooms. What can we use now instead? So where is the industry going? How has it managed removal of, you know, one of these really common products?
Yeah, no, thank you. And I saw one of the questions actually popped in, you know, regarding that as well in the chat box, Q&A, sorry. Now, since the ban of the engineered stone, now they're using new products, you know, obviously commonly referred to as zero silica or sort of that sort of products. But I mean, literally most products are recycled glass, and because recycled glass is mainly amorphous silica, not crystalline silica. So because by legislation now, these products, any of the products that they use as panels, slabs or bench tops has to contain less than 1% of crystalline silica. So so they're more amorphous forms of silica. That's what so they're still very emerging because since the ban last year, so there are a lot of products coming. I actually spoke to a New South Wales Safe Work silica compliance officer last week, and then what he said was, you know, because they go out to workplaces to inspect those places, and now one of the problems is because a lot of these new products are manufactured overseas, and once they come in, the only way to know what that contains is referring to their safety data sheet. And obviously you're relying on obviously a safety data sheet written by a person in overseas. We're not quite sure what that really contains. So it's really the employer's responsibility to get it tested, what that actually material is. So there are NATA accredited labs that employers can get tested, and also similar laboratories, which is similar to NATA accreditation. It's a real problem because because also these materials contains high content of resins and other material, which can also obviously can cause health issues. So the advice from the industry is that doesn't matter whether it's actually a free silica or not, because we still don't know what this material contains. Use it cautiously, apply all the hierarchy of control measures too when they're using this new material.
Thank you, Sugeesh and Janet. There are a few other questions which has sort of been covered, but two quick things. I think we did have some contact numbers at the end there that people could use to contact DDC, and I think that Lydia could correct me perhaps. I think that the Health Pathways has a lot of this information as well.
Yeah.
If people want to find out some more details. Thank you.
Thank you
That's
very
a pleasure.
much.
Thanks.
Thank you.
Thank you.